So I'm Kim Dittus. I am a medical oncologist, and I'm the medical director of our Oncology Rehabilitation program. So I'm going to kick things off. And I always feel funny saying medical director. I want to point out that doing oncology rehabilitation takes a village, and I have some of the village here. So this will be a sort of handoff in terms of talking about different aspects of the program. If you have any questions, ask them as we go along. So I'm going to start, and this gives a little bit of background about the history of oncology rehabilitation. And this is why this is so important. There are, at this point, this was data published in 2014, over 14 million cancer survivors, and that number is just growing across the country. And so that's wonderful. It's great to have so many cancer survivors. In 1970, that number was 3 million. But, and there are more cancer survivors because of earlier interventions, screening, but also improvements in our treatment. And our treatments, though, do have some collateral damage. And so now we're at a point that we can start to study and look at the impacts of our cancer treatment and try to prevent that or to at least ameliorate the side effects related to our cancer therapy. So I'm a medical oncologist, so I'm most familiar with things related to medical oncology. So some of the acute impacts of oncology therapy include fatigue. Fatigue is during therapy and often continues beyond therapy, and I'm having a hot flash. I'm going to take off my jacket. So additional impacts of oncologic therapy include deconditioning, there's a number of reasons why people might have deconditioning. Loss of independence, especially for individuals who are older going through cancer treatment, and then pain, nausea, vomiting, just to mention a few. So the lingering impacts of cancer treatment include fatigue. Fatigue is always at the top because fatigue is the most common side effect of our cancer treatment during treatment, and it extends often many years beyond that. Also reduced quality of life, potential cognitive changes. Maybe some of you went to the cognitive change chemo brain session. Therapy-related changes in function. If you have a surgery, you may have decreased range of motion, deconditioning, and being prone to other chronic diseases. So this is how we used to treat the long-term impacts of cancer therapy. So people would often be told, inaccurately, to take it easy during treatment. And they used to be told that by their physicians and also well-meaning family members. But taking it as easy is not necessarily the right thing to do. And they were told that they'd slowly get better over time, or perhaps that they should get used to a new normal, which was a phrase that would irritate a lot of cancer survivors. It would irritate me too. And we would, though, identify physical therapy for people with severe deficits. So if people had problems getting up out of a chair or needed a walker, then it hit us over the head. Oh yeah, they need to have some help in terms of interventions. So another thing that we know about cancer survivors is that they tend not to be all that active. But honestly, neither is the rest of the population. So you all probably know that we're supposed to acquire 150 minutes of moderate physical activity a week. This particular study looked at whether people were actually doing that. So they put that contraption on people's arms. It's an accelerometer. It actually measures your activity, measures whether you're doing something at a with vigorous intensity, moderate intensity, light intensity. It even tells you whether you're sleeping or not. So what this told us was that 87.3% of the general population did not meet minimum recommendations of 150 minutes a week. Cancer survivors, though, 95.5% did not meet that minimum recommendation of 150 minutes a week. So clearly, the general population, but even more so cancer survivors, need an opportunity to become more active. And we know that exercise improves survival for many different cancers at this point. Breast cancer has the most data. But also prostate cancer, colorectal cancer, and brain tumors. We know that individuals with those type of malignancies, if they're more physically active compared to less physically active, do better. So the recommendations for exercise are, and this is the American Cancer Society and the American College of Sports Medicine, to, number one, avoid being inactive if you can, and return to normal activity as soon as possible during or after therapy, to reach that 150 minutes of moderate activity a week, to also incorporate resistance training or weightlifting at least twice a week. And then the National Comprehensive Cancer Network, this is an organization that makes recommendations in terms of how to treat the latent lingering side effects. And in particular, they have recommendations for fatigue. And so for fatigue, we are to recommend optimal levels of activity. Exercise and physical activity, has the most data behind it in terms of preventing or decreasing fatigue. All right, and so now we're going to move into how we got started working towards providing interventions for exercise and potentially one-on-one physical therapy for cancer patients. So what is oncology rehabilitation? And you may have seen this in my slide from this morning, but to me, I think of oncology rehabilitation as using physical therapy and exercise modalities to improve or maintain function, to prevent side effects of cancer and or cancer therapy, and to improve fitness and strength. So it's not just one-on-one physical therapy. It's not just putting on someone on a treadmill. It's actually a combination of both and providing to cancer survivors the particular aspects that they need. And we know after we've started our program that some additional important treatments are to improve diet and potentially weight loss for most people, not everybody, but also stress reduction. So we emphasize that as well. And so the cancer survivor continuum, someone is identified as a cancer survivor from the time of diagnosis going forward. But the needs are quite different if you think about at the time of diagnosis versus right after chemotherapy versus maybe 5 years after chemotherapy. And so we've divided it up a little bit into around the time of therapy and post-therapy as sort of phase 1 and 2, similar to cardiac rehab, and phase 3. And we started with the post-therapy situation in August of 2011. And here our goals for the post-therapy intervention is to provide interventions for individuals who are deconditioned as a result of cancer therapy to restore function. So for example, with breast cancer, maybe range of motion is an issue because of surgical interventions, lymphedema management, fatigue management to improve exercise capacity, and also to jumpstart people in terms of lifestyle modifications that might be beneficial for them. So we are, as far as I know, the only place in the country that has an oncology rehabilitation program set up the way ours is set up. So we provide oncology rehabilitation in a cardiac rehab situation. So there are cardiac rehab sites across the country, and very often they are underused. And ours is not quite so much underused, but it provided us a space. So Phil Ades is always he is in all of my talks, because if it weren't for him and the support from physical therapy, we really wouldn't have gotten started. So he opened up the cardiac rehab gym for us to start this particular program. And so initially we had access to cardiac rehabilitation in the afternoons, and it's still, I guess, we don't have any morning times, but our times have definitely expanded. And then we were able to acquire some money to support a couple of exercise trainers at this point, and education interventions from donated funds. Onc rehab is not paid for by insurance. Cardiac rehab is. We're working on that. It'll take us years. Hopefully at some point it will be reimbursed. We started in August. And so the way we have this set up is we have monitored aerobic exercise and resistance training. We always include the resistance training because we know that individuals who have had cancer therapy tend to have muscle weakness as well. And that's sort of set on top of other interventions as needed, such as range of motion, physical therapy for range of motion balance problems or gait problems, fatigue, weight management, stress reduction. And not a lot of individuals are smoking when they come to us, but if they are, we work with them to try to move towards tobacco cessation as well. So we've modeled it as much as possible after cardiac rehab because we know that is a successful intervention. And we actually have a paper that will come out this month or next month in their large rehab journal that uses that as a model for maybe a way to provide oncology rehabilitation to people in the future. We do have an increase on emphasis on physical therapy compared to cardiac rehab because physical therapists have the skills that address needs across that cancer continuum. They can evaluate for many deficits, and they can provide exercise assessments and prescriptions. They're aware of the other rehabilitative services that individuals might need. And at this point, their services are reimbursed by insurance, and that's really important given that oncology rehabilitation as a whole is not reimbursed. So here's some things that individuals would need to go through. So to be eligible, anybody, any person who has or has had any type of cancer is eligible. We first started with breast cancer, but we've expanded to everybody. And at any stage of treatment and the recovery process with a physician clearance. So there's direct referrals at patients' requests if they call us, and we have Oncology Rehab Steps to Wellness booth, and so you can go and sign up if you want to, and we would contact you and figure out a way to get you involved. And then sometimes, or more frequently actually, there's a referral placed by the treating oncologist for people to come and see us out at Onc Rehab. And so this is our physical therapy evaluation. So we do evaluations before people end up coming in to the gym. The physical therapy evaluation lasts about an hour, and that's Diane, Michael, and Chris, our physical therapists that do the interventions. And this just lists some of the interventions that or some of the evaluations that they do. They will talk more about that later. They see a physician or a physician assistant, and we summarize oncologic treatments. We identify continuing cancer-related symptoms that might need interventions, determine referrals if needed. So inclusion criteria, in order to come into the gym, this is not a hard and fast rule, but pretty much a hard and fast rule. Oops, you need to be able to walk 6 minutes in order to be able to come into the gym. If you can't walk 6 minutes, without taking a break, chances are you need a little bit of boosting up with one-on-one therapy before you can come and exercise safely. You have to be able to be safe in terms of transfers also onto the equipment. And if someone were to have bone metastasis or even severe osteoporosis, we need to sort of think about bone integrity. So what do people get? So individuals who participate, they receive a tailored aerobic and resistance exercise program. And it is not necessarily a one-on-one intervention, but we have a core of what we provide. And then if someone, for example, has problems with balance, perhaps we're not putting them on the treadmill right away because we don't want them flying off the back. Perhaps they use a different aerobic equipment. Or Diane may say, you know, this person can start their resistance training, but they need to be careful with this type of movement. And then the exercise trainers, there's 2 of them that we have, they will then progress the exercise prescription. And then we also have weight management and stress reduction classes available as well. Is this you now, Diane?
She's a lot taller than me. I'm very short. So I'm the physical therapist that started with the Steps to Wellness program. We've now expanded, and there's multiple physical therapists involved. So when you come in to see us, the first thing you'll do, one of the first things you may do, you either see the physician or you'll see a physical therapist, or somebody refers directly to us and thinks you may need physical therapy services. We may see you and screen you and see what you needed and what we needed to address. So the first thing we do in PT is we're going to screen for bone and joint problems, musculoskeletal problems that may require some special adaptations for you when you're participating in a gym program. If we find something, say you had a total knee replacement and you shouldn't be kneeling, we'll refer that on to the exercise text and make a notation for the exercise text that this person needs to do their exercises in a seated or standing position. We screen for lymphedema. I have to say the physicians screen as well, if not more so. We collect functional data. There's data out there that tells us whether you're at risk for falls or not at risk for falls. One of them is simply, how fast can you stand out of a chair 5 times in a row? So that'd be one of the tests that we do. We screen for balance. People will come in and they'll see us doing balance testing, and that's to make sure that you're safe with your balance, that you're safe to get on and off the equipment, and also if you have a balance problem, so that we bring that onto the exercise text to make sure that they work with your balance on that. If it was very severe, in that case, we might make recommendations for one-on-one therapy. We review the findings and recommendations with your physician, meaning the physician who is seeing you. So Kim Dittus or Patty O'Brien or Penelope Gibson, who's a PA that does screenings, we actually sit down and talk together. It might be briefly, but we talk together and make sure that this is the best fit for you or any adaptations that may need to be made. We determine if formal therapy is needed. Also, would you need one-on-one PT? Are the deficits such that it would be better for you to do that before you came into Steps to Wellness? Do that while you're in Steps to Wellness? Do you need a speech and language pathologist? Are you having some difficulty with motor control that happens with some cancers, typically not breast cancer, but some other cancers it can? Or do you need an occupational therapy referral because you're having difficulty with your elbows or your hands, or you need some splinting done in order to participate? And we can move on. Oh, I can move it. Okay, sorry about that. So the PT evaluation, we also look at where you're having pain, and is that something that's been chronic in nature and that you're managing well, or is that something that you need a referral so that that can be better managed and it doesn't impede you from participating in exercise or impede your function as well? So we look at that. Do a very quick postural inspection. We look at range of motion. In the breast cancer population, a lot of times there's restrictions in arm movement. So things like putting dishes away might be difficult for you. For females, hooking your bra strap, tucking in your pants in the back. So we may look at that and how is that related. We look at your strength, and again, Kim already stated that a lot of times you have strength deficits in your extremities, and especially if you've had chemotherapy, we have what's called proximal muscle weakness. In other words, your shoulders, your hips might be very weak, which is impeding your function or making you very tired at the end of the day because you struggle because those muscles are so weak. So we'll look at strengthening those as well, and where do you need to be strengthened. Sensation is really important. Some of the chemotherapy drugs actually cause neuropathy or decreased sensation in your fingers and your toes, and that can make your balance off, or we may need, or make it very difficult to hold objects and things like that. So we look at that as well. The balance we already did, and then we have you fill out a couple of surveys about your arm and leg function, so that gives us a better direction of where to look and what do we need to be addressing. Okay, the upper back muscles, what we find again that you get very weak in these shoulder blade muscles, which are the muscles that stabilize your shoulder for movement. So we found that there's significant weakness there, and we make sure that we check those. 30-second arm curl test is just a way to see how strong your arms are. We look at your trunk muscles because, again, you get that proximal muscle weakness, so we want to make sure that your core or your stomach and your back muscles are really strong to support you. The 5 times sit to stand, we already talked about. The dynamic gait index, that's an index that shows whether you have some balanced issues or not. A lot of times we'll have people walk forward, we'll have them turn their head, especially if they've had chemotherapy or been very inactive, and you'll see this kind of weave pattern. And you say, okay, what does that mean? Well, that means that if you're outside and you're walking on uneven surfaces, you may fall. Or if you're using a vision a lot to balance with, if you're getting up in the middle of the night and you haven't turned the light on, you're at higher risk for fall if your balance functions are not back to normal. So we work on getting those back to normal. Single leg stance is just standing on one leg. How long can you do that? And then we take the vision away and see what happens to that. After that, is this still me? Okay, after that, we can make a referral directly to Steps to Wellness, and usually at the end of my evaluation, if you're appropriate and you're interested, then we sign you up right there and then for the Steps to Wellness and get you started, and usually it's about 2 to 4 weeks after the evaluation. If you're not quite appropriate, we may do both. It may be that you need a little range of motion in your arm, but you're still going to be safe to participate in a gym, so we might have you do both at the same time. If you're not safe to be in the gym, or there's another medical reason why you shouldn't be in the gym, then we'll make the appropriate referral recommendations to the physician, and they'll make a referral to PT, to OT, to cardiology, whatever needs further addressing, and to make sure that you're getting the best care possible that you can, and also that you're exercising to get the best results that you can. And I think now it's time for Rebecca, who is actually our one of our exercise trainers who does a great job moving people along. Thank you, Rebecca.
All right. here. So I'm one of the exercise trainers at the gym. I just reached my 2-year mark there last week, so I've been there for quite a while. So this is just kind of the road that goes into the gym. We're at Tilley Drive in South Burlington, so not really in the hospital. Beautiful mountain view when you're doing your resistance training. So the 12-week program is 12 weeks, and patients come 2 times a week. And it's supervised always by either myself or Britta, who's the other exercise trainer. So we're always there in the gym helping to modify and progress patients. So we at least need a bachelor's degree in an exercise-related field or an ACSM personal training certificate. All right. So after the findings of the PT eval and they are scheduled for a new group, they start with us in a kind of intimate setting. So there's up to 6 participants, and each group starts every 3 weeks. There's always kind of an enrolling groups that start. So we have the Monday, Wednesday group, Tuesday, Thursday groups, and that extended time was the 1 to 3 time in the afternoon. So the first 3 sessions, I guess I should say, is where the groups meet each other. They learn what the exercises are, and they learn technique and ways to safely do each exercise. And then they're also modified per individual needs for those patients. So the nice thing is that it's less than 6 patients, so it's really kind of that intimate, getting to learn one another and learn from us in a small group. So the 4th session is where the participants are a little more independent, so we're not kind of right on them. They're starting to actually learn the program and do it themselves. And then each person can come in within their allotted time. So say they were Monday, Wednesday, 4 to 7. They can come in anytime from that 4 to 7 time that works for them. So program materials, I kind of brought one of the binders. So every patient gets a binder when they come in. And it's a really cool tool, and it has their exercise logs in them. So they fill out these logs every time that they're here. And that way they can see their progression in 12 weeks, and then also we can check their progression as well. So we can see kind of where maybe they aren't progressing and then check in with them as to why, or actually see that they're doing really well and progressing the way that they hopefully should be. And also it comes with the exercise packet, which shows every exercise, pictures, and how to modify each one as well in the book. So this is the kind of the exercises that we do. So it starts out with balance training, and then it goes into lower body, core work, and then upper body. So each time that the participant is there, we do cardiovascular training, and Britta and I check heart rates every time that they are exercising. And heart rate ranges are based on ETT findings, so that's a stress test that participants, most of them, get in the beginning before they start. And this gives us a really precise range on where to work the participant or where to have them in their intensity, so for the most cardiovascular benefit for them. This is the kind of a chart broken down in how we try to progress them up to 40 minutes within their last session. So really trying to increase the duration and the intensity of their cardiovascular training. And we try to work normally between 70 and 85% of their VO2 max. Data points for us. Within their 2nd week, normally we do 1 rep maxing. So 1 rep maxes are testing their maximum strength. And this gives us kind of a level of where to start them and how to progress them by their max strength. We do chest press, leg extension, and leg press. At the end of their 12 weeks, we do the post-testing. We do the 6-minute walk again, the balance, and the 1 rep maxes. And this really is kind of the rewarding part of the program, where we get to give them a report card and show them their progress, or a progress card, and see what they've done in 12 weeks and what they can continue to do. And I think that's the best part. There we go. Oh, and they get a certificate. That could be you.
So in addition to exercise, we also teach healthy living through nutrition and stress management, which tend to be areas that a lot of people need support in. So to begin with, we have 2 lectures, one on nutrition, one on stress. And these lectures cover not only the basics of these topics, but also specifically how they relate to cancer. And we offer each of those lectures once a month. And we really encourage everyone to go to both of them at some point during their time in the program. In addition, for people who need more support or want more support in one of those areas, we have class series. So we have a 4-week weight control class, and that class covers not only what to eat to lose weight, but also behavior change. So helping people identify what their habits are around food and how to change those habits. We also have a 3-week mindfulness class, and that class teaches basic mindfulness techniques such as breathing exercises and meditation to reduce stress. All of these lectures and classes take place at in a conference room at the gym, and they're all during our regular Steps to Wellness hours to make it easy for people to attend them. And participants learn about these lectures and classes, and they sign up for them during their first couple weeks in the program. They can always make changes to their schedule later if necessary, and they can also take part in the classes after they've graduated if for some reason it doesn't fit in their schedule during the 12 weeks. So at the end of the program, we discuss and document with each person what they plan to do for exercise after they graduate the program, because we find that if they don't have a plan, they tend not to do anything at all. So usually people have already given this some thought, but if not, we help them to make a plan. Some common options that people like are joining a gym near their home. Sometimes people have the exercise equipment at home, so they choose to do it on their own. And another really popular option is getting a membership to our gym, the Steps to Wellness gym. It's a great way for people to stay in touch, be part of the community, stay friends with the people they've met. And a lot of people also just say they feel more comfortable at our gym than other gyms. And we also, of course, encourage people to take part in other programs that exist for cancer survivors, such as Survivorship Now and Live Strong. And at this time, when we talk about this, we also check in and see if there's anything else they need. So if they want to do our weight class but missed it before or something like that, we make sure they have the information so that they can keep doing these things. Another thing we offer to graduates is alumni events. So for example, going to a yoga class together or going for a hike, something like that. We announce these events via email and Facebook. And they're really a great way for us to stay in touch and support our alumni. And they're also a great way for people to get back on track if they've stopped exercising. It's a little boost of motivation. And then one last thing I'll mention that happens after the program, it's not listed up here, but we've recently started a follow-up survey. So about 3 months after people graduate the program, we send out a survey just as a way to check in and see how people are doing, see if they're still exercising, see how they're doing with diet, fatigue, stress, quality of life, their health in general, all of those types of things. So that way we can see not only how they progress during the 12-week program, but also how people are doing a few months later and how they're applying what they learned to their life beyond the program. I'm going to turn things back to Kim to talk about some of our results.
I don't think Kristie introduced herself. This is Kristie Grover. She's our survivor navigator. She's the one who helps people through this whole system and really helps to motivate people to plug them into things afterwards as well. She actually is a PhD trained psychologist and has a real interest in lifestyle interventions. So I'm going to then talk a little bit about the results from our program. So as I mentioned before, oncology rehabilitation is not paid for by insurance, and I think that's sort of sad and actually a little bit of a travesty. But there isn't enough data available for insurance companies to really pick this up and pay for that. So what we decided right from the start is that we needed to collect data before people start the intervention and after they start the intervention, so that over years, and that it will take many years, we will have data to identify the benefits provided by the program. So we collect information about fitness and strength, we collect information about balance and range of motion, about fatigue and sleep and quality of life and anxiety and depression. We collect a lot of data before and after, and it's all put on a database, and it's all IRB approved, and there's nothing different that we do to people. They just allow us to put this information on a database. So as of June, there were 338 cancer survivors that we had evaluated. Now it's over 400. 80% of those started the program. Some of them needed additional one-on-one physical therapy. Some of them maybe found us, but they really lived too far away in order to participate. And then of the people who started the program, 71% completed it. And actually, that's a very high completion rate. Cardiac rehab is envious because they don't have that completion rate. So sometimes people need additional one-on-one physical therapy. It turns out that that's the case for almost 12% of individuals, that they need some additional one-on-one physical therapy. A smaller percentage need to have some cardiopulmonary intervention before they can come as well. So some primary reasons why people might not finish the program is that they may have developed some additional medical issues. That's the most that's a common intervention, or work and travel, just life interfering. But that's not that many individuals when you think about the numbers that have started. So when we first started, we piloted this with breast cancer survivors only, but we now have anybody who with a cancer diagnosis is eligible. It still tends to be primarily female, primarily breast. And individuals find us at various times after or even during treatment, and they have a variety of oncologic interventions. So here's some of the data. So do we have benefits from what we do? So we do that 6-minute walk test. Most people can do it, and so that's not that big of a concern. But post-test, they can definitely walk further than they could before. And at the time of doing the first test, 42% of individuals have a time that's below what we would expect for predicted distance that they can travel. So exercise tolerance test. So this is similar to what you would do for cardiac rehab. We put you on a treadmill, and Dr. Lukoski, who's the cardiology that works with us, and some of our exercise physiologists will run you through a exercise protocol on the treadmill to look for what your peak VO2 is, so your peak aerobic capacity. And so what we find for individuals who enter the program, which is the lighter blue bar, is that their fitness level is kind of poor, like pretty poor. Over 70% of individuals who enter the program have very poor fitness for a variety of reasons. And you see that afterwards, if we do an exercise tolerance test afterwards, there are fewer people in that very, very poor range. Still a number in the very poor range, but we've managed to shift people in 12 weeks towards having better peak fitness. And I think the strength information is also very telling. And this is for breast cancer survivors only, because you need to kind of homogenize people when you're going to make comparisons. Because as much as I'd like to think I'm as strong as a guy, I'm not. So this is just women who have had breast cancer. And so when we do those 1 repetition max tests that Rebecca talked about, the exercise trainers actually do it, we know that 84% of women, in this case breast cancer survivors, are at less than the 15th percentile or very poor in terms of strength for chest press, doing a 1 repetition max chest press, so measuring upper extremity. After the intervention, 68% are at less than the 15th percentile. So still a majority are weak, but they've shifted to having fewer people in that situation. Now you might say, well, that's the upper extremity, and obviously for a breast cancer survivor, that's what's impacted most by treatment, such as surgery. But we also find that lower extremity strength is also impacted. So almost 80% of individuals are at less than the 20th percentile, or well below average for leg press or lower extremity strength. This improves actually quite a bit to being 37.4% of individuals who are less than the 20th percentile. So again, we don't make people into super athletes, but we definitely shift them into being less weak and more aerobically strong. And so this just shows that after the intervention, there's a significant improvement in lower extremity 1 repetition max strength testing in pounds for the lower extremity and the upper extremity. The lower extremity strength increases by about 16%. The upper extremity strength increases by about 20%, both statistically significant improvements. We also see declines in depression and anxiety. Now, just to put this into perspective, individuals who attend our program, so 5 is a cutoff for mild anxiety and mild depression. So you see that individuals in our program don't have significant problems with depression, although it does range from nothing to high levels of depression. And then Kristie picks that up and has people enter into some, like the cancer patient support program, or make sure that there is some intervention in that regard. And then anxiety also. But either way, those decrease. And the most important thing, at least from my standpoint, because I know that our treatments can cause a lot of fatigue, is that the fatigue levels before and after the program decrease by 54%. So that is a significant improvement in fatigue. So that's just an example of one of our groups. So we'll take some questions at this point. And I can't believe we got through all those slides. Do any of you have any questions? Yes?
Did I hear it's a gym that anyone can join, cancer or not? You can join it like
Yeah, not quite. It is a gym. It's sort of a medical rehab gym, though. It's the cardiac rehabilitation site on Tilley Drive. And so individuals who have cardiac issues, cancer issues, and pulmonary issues can participate. And after cardiac rehab or oncology rehabilitation, if people want to continue, if they're one of our graduates, they can pay a small fee and actually continue. It's really quite a good price. So even a cancer survivor, like 10 years out, 15 years out? Absolutely. So at the Oncology Rehabilitation Steps to Wellness booth, there's a place where you can sign up. And what we would end up having to do is contact you, and we do need to have a physician referral, but sometimes Patty O'Brien or myself can put that in for you and get things started in terms of the program. All right. Yes?
Diane, your PT valves covered by insurance?
My valves are covered by insurance, yes. The vast majority of time, I think in those 400 patients, we've maybe had 2 or 3 that were not covered, and fortunately, through donations, they were covered through that.
Yeah, so the physical therapy evaluation is paid for by insurance. The physician evaluation is paid for by insurance. And the first exercise tolerance test is also paid for by insurance. But we do have a program set up so that if for some reason, and this doesn't happen frequently, if for some reason somebody's insurance doesn't pay for it, we do find the funds to pay for it. For physical therapy, sometimes if someone has had a lot of physical therapy that year, that's where we sometimes get into trouble.
It's important to note, too, that the program itself is free. So
Yes.
even though insurance doesn't pick it up through donors and small grants and things, the program is free to people who participate.
Yeah, that's really important. And we raise money through a variety of ways. We've even had bake sales to raise money for Onc Rehab, actually successful bake sales. And but we also, like the medical student team that runs in the teams that run in the Vermont City Marathon, raise money for oncology rehabilitation. And so that's what pays for the exercise trainers and other philanthropic things, the survivor navigators and that sort of thing. because we don't have insurance reimbursement. We will. It'll take us a number of years, but we will get it at some point. All right, if you have any other questions or want to talk to any of us about it, you can catch up with us either up here or at the booth down in the main area. Thanks for sticking with us in this very long day.